Thank you very much, John, and welcome everyone to our final week, week 4 of our open access course as part of our One Health, One Medicine series on refugee and migrant health. Interestingly, as we begin the final week and conclude this course, we reflect on our first 3 weeks. In our first week, we engaged a conversation with a presenter who served as a refugee herself. In our second week, we shared in the experiences of a coordinator of a refugee camp. In the third week, we engaged in a discussion from a caseworker who supports and assists refugees who relocate to host countries. And in our fourth week, we present the perspective of refugee health with a focus on the Syrian refugee crisis, especially from a health systems perspective. We have with us Dr. AhmadFiras Khalid, who is a graduate from St. George's University and who has spent a lot of his time notably working with refugee communities, and that is a critical aspect of our health. Throughout this course, we have begun to appreciate that a significant proportion of the planet are persons who face displacement. And as a result and consequence, there are inequities, vulnerabilities as it relates to their health and well-being. So we have with us today Dr. AhmadFiras Khalid from McMaster University, who will be sharing with you his experiences, his thoughts, and engaging you in questions and comments as well in our final week of our course on refugee and migrant health. Without further ado, we'd like to welcome Dr. Khalid to our course, and we look forward to your seminar presentation.
Thank you so much for that. It's a true pleasure for me to join everybody here today on a topic that's very close to my heart. I think that overall the refugee crisis is going to be, if not the biggest challenge that we will face as healthcare providers or anybody that works in the healthcare system for the next decade or so, if not more. Today's presentation, I really want to focus just on the Syrian refugee crisis and give you an illustration through a health systems approach towards how to deal with this refugee crisis. Basing it on a system, the Lebanese health system, that has been able to show resilience in being able to address a crisis that had quite considerable consequences in a community that struggled for years and years to host the large influx of Syrian refugees. So today, when we talk about health system resilience, the question that I often get asked is, like, what do you mean by resilience? What does that notion mean? And I think resilience is just the system's ability to absorb any kind of shock. And in this case, the shock is this massive influx of Syrian refugees that crossed the borders from Syria after the civil outbreak that happened there into Lebanon. And as you see from my second slide, which I'm sorry, just bear with me, I'm just navigating the system. 1 in 5 Syrian refugees now is a refugee in neighboring countries. I think one of the most fascinating things for me from my work for the past 5 years on this is that there is this misconception that refugees are isolated into 1 or 2 communities, but in reality, actually, refugees are everywhere in the world. They just happen to be in larger, dense numbers in certain countries. And often we find that refugees, in the case especially the Syrian refugees went to neighboring countries that opened their borders or allowed them access. And an example of that would be like Lebanon and Jordan and Turkey, where we've seen the massive influx of Syrian refugees. But that doesn't mean that it only happened in low resource communities. We've seen Syrian refugees here, for example, in Canada, where I'm based. Canada has taken up a leadership position around 2014 to accept more than 54,000 Syrian refugees. And the numbers are only continuing with an increased Liberal government commitment to welcome more Syrian refugees into our communities. Now, having said that, the way it plays out in a low resource setting, as compared to, for example, Canada, which is a high resource setting, is that because of the context that the Syrian refugees come in, if the system is not willing or is able to adapt to that large influx of Syrian refugees, it can go in either direction. The system, the health system specifically here, can either collapse because it cannot cater to the large influx of Syrian refugees that come with the non-communicable diseases being the major cause of burden on the health system, or it can shift its resources and rely on certain things within the system that's been established to help build its resilience to be able to absorb this big shock. And when we look at a health systems approach, I think it's very important that we remind ourselves and contextualize that in what is a health system? How does that function and what does it look like? So there's been many numerous ways to describe health systems. I think the WHO provides sort of an overarching umbrella that's been adapted by different scholars in the field. When we look at a health systems, for me, it's very easy to think about it as a building block of a house. And sort of on top of that would be like the governance arrangements, like who makes what decisions and how are they regulated? And then we look at, for example, delivery. So how is care being delivered to the people that need it the most? What support structures are in place in that context that help leaders or providers in this case to support the delivery of care? And that involves, of course, health workforce. It also involves information technology, with the use of electronic health records becoming a mainstay of the way we deliver health services. We are seeing technology actually play a very instrumental role when it comes to dealing with Syrian refugees. And I'll talk a little bit about that later. But also when we look at health systems, we must remind ourselves of the financing and funding models. How are we going to be able to have enough financial resources, not only to deliver the care, but often we need money to train our healthcare providers to be able to cater to this new demographic because they present with different health challenges that require new training. And also, of course, as with any health system around the world, there's a sense and urgency for leadership. And that leadership comes in terms of networking with different stakeholders, but also in figuring out how to adapt the system effectively so it can respond to the crisis in an efficient way. When Lebanon in particular is a very specific example and close to my heart, because the reason why Lebanon stands out as one of those countries that's been able to be sort of an exemplar of a Lebanese health system is because Lebanon is technically a low resource country. It doesn't have a lot of funding and their health system is unique. And by that I mean is that it's mainly a private health system. So there is very little public health provision of services and it's reserved for the very underprivileged and often it requires individuals who will come from a low resource background to request permission to get access to free health services. So it's mostly a private health system. And with that comes the burden of how are people, Syrian refugees specifically, going to be able to afford care in a country that's mostly run by the private health system? So one of the facts about the Syrian refugees that manifested itself during the Lebanese, in the Lebanese context, like 16% of the Syrian refugees who came to Lebanon needed primary health care in the first half of 2016 and couldn't access it. Now, many researchers looked into some of those barriers, like why is it that the system was not able to provide primary healthcare coverage to Syrian refugees that were coming in? Some of those factors have been political factors. So, certain parties who, Lebanon again is a unique context where you have to have different parties that represent majority in the government to make decisions. So if you want to think about it in a US setting, it's sort of like they have to have an equal Democrat, Republican, and independent in order to make a decision. It's a very unique setting for Lebanon. And with that complexity comes the difficulty to be ensure that decisions that are made at the most senior level are being translated to, for example, the Ministry of Health level in order for them to put forward strategies to enforce the primary health coverage within the country. And so what happened was you've had more than 1 million people coming into Lebanon during the Syrian outbreak, the civil war outbreak. And the primary healthcare networks that were already set up in the country just didn't know how to deal with that. And there was a massive gap in the provision of healthcare services to Syrian refugees. And whenever there's a gap, we often find that key players in the sphere, in the spectrum of international humanitarian aid, step up. And so we saw, for example, the UN agencies and various non-governmental organizations step up to fill up that void of providing primary health coverage to the Syrian refugees. And often my work in Lebanon, I spent months there trying to figure out exactly what happened. And what we saw is that many people spoke about this parallel health system. So you had the existing national health systems operating, providing services. And where there were gaps in that system, the NGOs and the UN agencies stepped in to fill that gap. So the problem there is when you have two parallel health systems running at the same time, you have diversification of resources. And also it was very difficult to figure out where were the problems, where are the infectious disease outbreaks, the maternal mortality rates that were happening, because the reporting between the two systems that were happening at the same time wasn't cohesive. There was no way between the two systems to actually collaborate and connect with themselves to figure out where are the gaps that need to be filled by who. And just to give you an indication about the plight of the Syrian refugees in Lebanon, a recent survey saw that Lebanese host communities have quite negative perceptions regarding the extended refugees present in Lebanon. And I saw that firsthand when I was in Lebanon. I think Lebanese people are very gracious people. They're a very welcoming host community. They've demonstrated that with accepting the massive influx of Palestinian refugees back in the day. But because of the Palestinian refugee crisis in the past, this sort of left an interpretive effect among the people in Lebanon to say that we're already a low resource country and this burden on us is just, it's too long. It's been going on for too long for us to be able to handle it. And so we saw a lot of tension between the communities there of people, Lebanese people saying, you can't provide healthcare services to the Syrian refugees without adequately also providing healthcare services to us first. And so this what made the system sort of a shock to the system to be able, can you adapt enough to not only provide resources to the Syrian refugees that are vulnerable and require that help, but can you also manage to ensure that you adequately support the Lebanese host communities? And also, I talked earlier about funding and being a big issue in any health system. And here we saw that the international donor money was not fulfilling the gap. So especially when it comes to health, 7.5% is the gap left remaining of international money not going into health. And you know, I will share with you one very fascinating thing for me as somebody who's traveled the world in different capacities and saw different health systems, is that Lebanon is a massive sort of playground for NGOs and UN agencies. I have never in my life actually been in a context where I witnessed the diverse number of NGOs. I mean, you could literally spend hours listing how many actors involved in humanitarian aid exist in Lebanon. This could partly be due to the fact that it's a low resource income country and requires the help, but I think it also speaks to the idea that it's a country that struggled for a long time with different crises. So whether it's their own civil war, as they had different shifts in government, or with the Palestinian crisis, and now the Syrian. So it's just a context that requires a lot of aid over time. Unfortunately, that aid is not always going to the health needs of people, and partly because of corruption in government, but also because, as I said earlier, this parallel health system has diversified where the funds go. So there's never been clear channel as a donor to realize where the money should go best to allocate to service delivery. When we look at humanitarian aid response, it's very important that we think about how does that play out. So I recognize that a lot of people do not necessarily understand how a humanitarian aid crisis works or the response to a crisis. So I wanted to illustrate to you that it's usually a cyclical cycle. So it goes through a needs assessment and analysis. So we figure out what are the needs of people in the crisis. We then put forward strategic planning about how to address it. We mobilize resources. We implement programs, we monitor them over time, and then we evaluate it to see how can we improve on that. And along this response cycle, there are many players that play a factor. And among them, as you can tell from my next slide now, we see that, this is a perfect example in Lebanon. So we see WHO playing a very prominent role, the WFP, UNICEF, UNHCR, we see IOM, which is the International Organization for Migrations at the UN, UNDP, Save the Children, the list goes on, and each one of them has their own sort of jurisdiction. So they all work within their own specific programs, and there's actually very little collaboration among them. But what happened in the case of Lebanon is because of very strong leadership and a governance model already in place, arguably by the Director General of the Ministry of Health there, they were very effective in sort of leveraging the networks they've had among those different organizations that have been there for a very long time. and utilizing those different networks to establish what they called then in 2014, the health response strategy, which was a set of policy options to unify and unite the different organizations and able to put forward some concrete ways to address the health needs of Syrian refugees. And they've really only been able to do that by leveraging the different networks they've had in place. And this also helped them allocate the funds accordingly. So when you have so many different organizations with different mandates, they also come with enormous funds. So it's a matter of having a structural health response strategy that helps to figure out where is the best way to allocate those funds to address the health needs of Syrian refugees. But we also saw that it's not necessarily just about funds and networking between different organizations. Sorry, I just realized I skipped the slide. We also saw it in terms of the existing health structure itself. So Lebanon, because it's a private health system, and with that comes a bit of resources, they actually have in place quite fantastic hospitals and primary healthcare centers throughout the country. There are obviously gaps that still need to be filled in terms of primary healthcare centers enforcement. But during the Syrian refugee crisis, what they realized was, A, we need to train our healthcare providers better to address the health needs of the Syrian refugees, but we also need to mobilize the infrastructures we have in place in order to allocate services accordingly. And the way they did that was they've shifted their model from a hospital-based model to primary healthcare center model. So then now what they tried to do is make sure that Syrian refugees in certain communities within Lebanon were able to access primary healthcare centers at a much better speed. And by doing so, not neglecting the actual community that lives, the Lebanese community, because they recognized that tensions were rising in communities where there were primary healthcare centers that weren't addressing the health needs of the Syrian refugees first. We also, because one of the big things that come with any crisis, regardless whether it's a refugee crisis or not, is that there was an increased number of infectious outbreaks in Lebanon during when the Syrian refugees started emerging. One of the most particular one was leishmaniasis, something that Lebanon hasn't seen before, and it was very unique to the setting. So that required training of the healthcare personnel to figure out how to actually deal with this infectious disease. But because Lebanon already had a very strong immunization coverage programs in place, and because they utilized also an early response system that they had, they were able to combat infectious diseases at a remarkable rate that we haven't seen in other host communities. So when we compare the Lebanese health system to other health systems of countries that have taken in Syrian refugees, we noticed that they were able to actually deal with infectious diseases that come along with having a massive influx of Syrian refugees into their community at a much better rate. And that speaks to the resilience of the system. And primarily that is due to two main reasons, is that they had a very strong immunization coverage program, and they also had a very good early response and warning system that helped alert the Ministry of Health whenever there is an outbreak happen. And one of the things that I've noticed as speaking to many different stakeholders there is one of the key problems of the parallel health systems that happened at the beginning of the response was when an infectious outbreak happened in a remote setting, and an NGO or UN agency was able to identify it, it didn't always get to the Ministry of Health level. And that caused a shock to their system to be like, we need a better strategy to make sure that we get ahead of this so it doesn't go out of control. And then I think what's important when we speak about resilience of a system is this idea of integration, which is also, again, unique, very unique to the Lebanese health system. If you're familiar, and I hope that the previous speakers have talked about this in the seminar, most often we find actually historically refugees have always been sort of put in camps. So that's usually the default mechanisms of dealing with large influx of refugees. We tend to want to put them in a, like, for example, the biggest camp in the world is Zaatari camp in Jordan, which houses now more than 1 million refugees in it. Lebanon, on the other hand, took a very different way to deal with the refugees. They said, we will do a non-encampment rule. So Lebanon is one of the unique settings where they don't allow camps in their countries, because primarily of what happened with the Palestinian refugees. They saw during the Palestinian refugee crisis that the camp setting didn't work. It wasn't conducive to delivery of care. There was a social isolation of the refugees, and there wasn't better integration into society. So for Lebanon, when it came to Syrian refugees, they made a very governance rule to say that, no, we're not going to put the Syrian refugees in camp. We're going to try to better integrate them into our urban settings. And by doing so, they were able to utilize the existing infrastructures that happen to already exist in an urban setting. And by that, I mean the existence of strong primary healthcare centers and hospitals. So it's easier to provide healthcare services to them. And that's actually a key lesson to learn for future communities, whether it is Canada or the US or any other setting that's looking to welcome Syrian refugees, is that the idea is not to isolate them and put them in a camp, but the idea is like, how can we better integrate them into our society? Something I could tell you that here in Canada, we've sort of tried really hard to sort of learn from the Lebanese health systems about that. When we accepted Syrian refugees in Canada, it was an intentional motive to make sure that they're better integrated into our communities. And I'm not sure it's always working to the best of its intention, but I know that there are very concrete efforts across the board to figure out how that model works. And then I think what's important to realize is that when we look at resilience of health systems, and when we speak about the Lebanese health system, sorry, I just seem to have a issue with the slide. Okay. What does that mean for the other systems? So I want to sort of end my seminar and I can go on about this topic for hours, but I think it's what I really wanted you to get across, what I wanted to get across today in the seminar is to give you an idea, because I think that when we often talk about this, the refugee crisis, regardless whether it's Syrian or not, we tend to focus very much on the negative connotations that come with them or the challenges that come with them. And there's no denying that with any refugee crisis, there are massive challenges that come, but there are also glimpses of positive things that can sort of, that we can inspire us to continue our efforts to better address the refugee crisis. And by looking at the Lebanese health system's resilience and ability to adapt to this large influx, sort of inspire us and acts as a springboard for further research into this area, but also for healthcare providers and anybody who's in the health system arena to think differently about how do we address this influx? How do we address the future? I believe the future, the major challenge of our future and our next generation is this migration issue. It's a serious problem. I mean, WHO just released recently one of the biggest challenges they believe we will face as a humanity in the next 10 years. And among climate change was migration. You know, migration is a topic that I think everybody needs to pay attention to, regardless of what profession you're in. But more particularly, people who work in the health system need to pay particular attention to this issue, because the reality is we will see more and more refugees in our healthcare clinics, in dealing with our health systems, able to adapt it to service them better. As educators, when we try to educate our students about how to deal with that. As researchers, we try to figure out innovative ways to solve complex problems. We could take the Lebanese example as a way to think creatively about how to solve a problem with a system approach, but there's also lessons to be learned from anybody else. So I hope that today's presentation sort of gave you a glimpse about what it is like for a system to step up and be able to respond to the refugee crisis. And I'm really open to any questions you might have and any follow-up questions after the seminar. I understand it's recorded, so I assume that later in the future, others who would view this, if you do have any questions about how a system was able to adapt to this, or what are some of the challenges that come with adapting to a large influx of refugees, I'm happy to respond to them.
Very nice. Well, thank you very much for your very interesting perspective as it relates to how a particular country example of Lebanon is working and adapting to the Syrian refugee crisis as well. And if I may begin just a discussion, what are some of the main points that I extracted out of your presentation was: one, primary health care is critical. Mm-hmm. For that reason, though, host countries that then receive refugees themselves, if their health system is not necessarily primary healthcare focused, then there may be a need for some sort of healthcare reform or emphasis on primary healthcare with regards to providing services towards refugees themselves. So that's my first comment. And for a country, let's say like the United States, how then do you see their existing health system being resilient, such as the Lebanese health system, if in fact they are to receive a similar type of influx of refugees?
Those are both excellent questions, and I'm not sure I have the perfect answer for them, but I could tell you that the primary healthcare centers or the primary healthcare, function in a system is something of pivotal importance across the board. So we saw that, for example, WHO is putting massive emphasis and focus at strengthening primary healthcare, because I think they realize that in order for a system to be able to adequately provide services to their population, whether it's refugee or not, there has to be in place strong primary healthcare. And in countries where that doesn't exist, we've seen a collapse of the system. I mean, the one example I give you is Jordan, because I've seen that in Jordan, because the primary healthcare is not as strong as it was in Lebanon, often refugees ended up having to get services from NGOs and international agencies, as opposed to going to the existing primary healthcare. And one just other challenge with that, with not having strong primary healthcare center, in Lebanon, there was one case of maternal death very early on with a large influx of Syrian refugees. And it happened because the woman at the time, the pregnant woman at the time, wasn't able to access services from the primary healthcare center. So she ended up delivering in her own home by the help of an NGO. And Lebanon actually has remarkable maternal mortality rates, very low ones, and they've been able to achieve Millennium Developmental Goals that have been remarkable for their country. And because of that little gap that sort of fractured the primary healthcare infrastructure, it was difficult for that. So that's a lesson to be learned for other host communities like the US, that when we're trying to advocate for the need to strengthen primary healthcare centers, this is one reason to look at it. And I'm also noticing that there's quite a few questions on the chat. So maybe I'll start addressing one at a time. Lisa, I really liked your question. Your question, just, I don't know if the people who view it can actually read the questions. Maybe it's best that I repeat them.
Yeah, maybe you can repeat it as well, but I'm seeing it, but certainly you can repeat it, yeah.
So the question is, how do countries decide how many refugees they can accept? Is there some sort of formula that takes into factors like current population and GDP into account? Again, a very good question. So it depends on the country. I can give you the example of Lebanon and then Canada. In Lebanon, it was sort of an open border policy at the beginning. Again, because like I said in my presentation, it's often what we see with the influx of refugees is it's always the neighboring countries that have the most impact. And that's just by geographical location. So the borders just got opened in Lebanon. So at the beginning of the crisis, Lebanese communities were very, hospitable and said, this is a vulnerable population that we need to take care of. They're escaping from horrific circumstances. They opened the borders wide and people flooded in, but then they shortly closed the borders because they realized that it's not sustainable. And right now, 1 out of 4 people in Lebanon is a Syrian refugee. So it was a very different way of looking at how they accepted refugees. In Canada, that's actually one of my big research topics, is looking at the factors that led to Canadian government to accept Syrian refugees. For us, what I found in my research after speaking to everybody here involved in Canada and that decision, we find that one of the big factors that sort of supported that idea was it spoke to Canadian values of inclusion and diversity. So the idea of accepting Syrian refugees really spoke to the core of what the Canadian values are. And the help of external media factors. So at the time of the Syrian refugee crisis, I think many of us can recall the picture of Alan Kurdi, which is the kid that washed up on the shores. And it was a very captivating image. And it really pushed, at the time we had elections here in Canada. And the Liberal government really stood up with that image that capitalized people's attention and made a very bold decision to say, if we are elected, if we become the majority government in place, we're going to accept Syrian refugees. And of course, there is the criticism that we haven't done enough, that 50,000 Syrian refugees is not enough. And I know from the Canadian perspective, the way they've chosen, just to answer your second part of your question, we actually were very strategic in how we accept Syrian refugees in Canada. Lebanon opened up the door to everybody. Canada didn't. Canada did an assessment. So we took mostly women and children. And we also used our networks with the United Nations for Human Rights, the UNHCR, for them to categorize and identify individuals that are technically on better health status. So they don't put a burden on our health system. So it changes from one country to another. The second question is, do you think that the US could do better, could better adapt to accept more refugees? And what are specific ways a primary healthcare provider could help facilitate and improve refugee health? Both excellent questions. I think the first one is it's a much more political question than it is a health system question. How can the US better adapt to accept more refugees? I think that Similarly to Canadian values of inclusion and diversity and acceptance, I think the US values are very similar in that. I think it just also plays out differently in the US. I'm not that familiar with the US political context, but I think what's important to remember is political factors play a major role in how we accept refugees, period. So it's very naive for us to think that it's only about having the values of inclusion and diversity and welcoming people. It's actually a lot of different actors who play very prominent roles in different systems that sort of help to mobilize a community to accept or not accept refugees. I think the rhetoric around refugees is changing. I think now there's a focus to say that instead of looking at refugees as a burden to a community, let's look at them as a resource. So recently I gave a keynote address where the focus of that was about how we can actually utilize this massive influx of people to our advantage in a host community. So I think the more we shift the conversation from it being a burden on communities to rather that we gained a massive resource. So a lot of Syrian refugees are, for example, healthcare providers, they're nurses, they're PT, OTs. That's a massive influx of healthcare workforce that we can utilize creatively and efficiently. So I think we just need to change the conversation out of that. And the second question is, and what are the specific ways a primary healthcare provider could help facilitate and improve refugee health? Listen, I'll tell you the truth. I think that one of the things that we noticed with the refugee crisis is that our healthcare providers were not adequately prepared to address their health needs. And so there was a massive shift in education. We had to invest a lot of resources here in Canada, but also in the Lebanese health system to train our cadre to figure out how to address their health needs. So this is calls for better ways of continuing education, whether it's at the medical school level, at the residency level, but also once you're already in the field. If you know that your community, for example, in Hamilton, in Canada, we've taken the majority of the Syrian refugees, healthcare providers should actively seek out ways to help themselves educate themselves about the needs of people. I'm wondering about sustainability. Are the Lebanese anticipating a rate of repatriation, or are the Lebanese expecting that these refugees are here to stay? Excellent question. Accepting that this is a permanent increase in their population requiring equitable long-term care. Deborah, I hope I'm saying your name correct. So right now, actually, as soon as I left Lebanon in January of this year, just a few months ago, and Lebanon actually has made a very bold decision to say that we want the Syrian refugees to go back to Syria. So it is changing. The government has shifted its policy, so now they've reopened the border with Syria, and they claim to have made an agreement with the Syrian government to welcome safely, and I emphasize safely because that's the big challenge right now. Are Syrian refugees who've been in Lebanon able to go back to their home country and live a safe life? So we're not sure about that yet. I think that's time will tell that. But I do know, as I showed in one of my slides, that the Lebanese people have reached a level of fatigue with the Syrian refugees in their communities, and there's a very, very strong push to sort of have them go back to their home communities. And I just want to say one more thing about that, is that this is why it's really important that we always address the root cause of the problem of the refugee crisis, and that is often the political unrest in their country. Is there grassroots efforts by local and national Syrian communities to aid in the acceptance, assistance, and assimilation? Yes, in Canada, and how can this be encouraged? I mean, if you type in Google, Canadian Syrian refugees in Canada, I mean, I'm always amazed about how the media here for us in Canada is so good at finding Syrian refugees that we've accepted and seen their stories over the years. Now we've had Syrian refugees for a few years, so we're able to assess the impact they've had on our communities. I recently traveled to the far east of Canada, to St. John's in Newfoundland, and I saw we've accepted a lot of Syrian refugees there, and I saw firsthand the impact they had on local communities. So the Syrian refugee as a population, they're very resilient and they're very adaptable. So they were able to come into our context and figure out ways that they can assimilate to our host communities. But I have to emphasize something. One of the things I keep pushing in sort of my advocacy for this topic is the idea is not to have them assimilate into our host communities. The idea is to help them integrate better. So we're not expecting them to change. Like we're expecting that the burden is on us as a host community to figure out better ways to utilize the massive resources they bring with them. And one of the key things when it comes to healthcare specifically is that in Lebanon and in Canada, the Syrian refugee doctors or nurses are not allowed to practice by virtue that they're not trained in Canada or Lebanon. So Lebanon has a very strict policy that only Lebanese trained physicians and graduates can work in Lebanon, and Canada has the same. We've opened it up differently. We have, as many of you know, the IMG stream here in Canada, but that's only for accredited universities. So all that to say is that we've lost a massive resource by having this like incredible, educated, skilled personnel, and it's a way to figure out how to better integrate them. And one other question, is there a reason why Lebanon does not have a universal healthcare? So they're working towards that. I think the reason it's policy legacies is historically the country has been run a private healthcare system, and they're moving towards a universal healthcare coverage. But like the US, it comes with challenges and it doesn't always work, and they're trying to figure that out. I mean, you have to remember that they have massive pressure by international donors because the country is pretty much run by international donors to move towards a universal health coverage. Are there any measures? By the way, I just want to interrupt this for a second to say I'm really amazed by the level of questions. They're very, very insightful about this topic. Are there any measures that can be used to engender the country of origin to assist, financial or otherwise, within the health care needs of refugees? I'm not quite sure I understand, Lisa, your question. I think
I guess if I may interpret as well, so refugees will come from a particular source country. So let's say Syria is a source country, their country of origin. Can there be measures to access resources from Syria to assist refugee communities in Lebanon or Canada, etc.? And I think that's the general sense of the question that Lisa may be referring to.
That's a good question. So I'm seeing that she's confirming that interpretation. Thanks, Satish. The reality is, I can tell you that truthfully, the Syrian government was very angry and is still very angry that their people left, that they became refugee. So the idea of them willing to support other host communities was never on the table. And I know, as somebody who worked for Doctors Without Borders in Geneva and was in charge of putting together a deliberative dialogue of getting people from the Syrian government to sit on that table to figure out, how do we do this? Like, you have this massive influx. And the reaction has been, quite honestly, that they need to come back. They should have never left Syria. So the engagement between the host communities and Syria was very limited. And it's only now that the Syrian government is open to engage in such a conversation about how do you bring back Syrians into their country. So just to give you an example of that, when I left, the UNHCR, in collaboration with the Lebanese government, was giving a per diem of, I think the figure was about like $60 a month or something, to pay for Syrians a basic salary to go back to Syria. So we will pay for your transport to go back to the country. We'll give you your medicines for diabetes or hypertension for 6 months till you find a healthcare provider back in Syria. And we're going to give you some cash money to survive on. The big problem with that is the security and safety of the Syrian refugees was never assured. So that's still a very sore and sensitive topic that's still trying to be figured out.
So I have a question as well. Now, throughout this course, we have engaged the issue of health of refugees, and one of the priority areas has been that of mental health. Now, from that perspective, especially from the context of where these refugees are coming from, mainly underdeveloped, developing country context, where mental health services or mental health awareness is even limited, how can you then engage refugee populations, communities on a mental health issue where for them, as part of their lives, mental health may not have even been part of the healthcare system or the conversation about health and well-being, when compared to Western countries, for example, where you have mental health legislation, you have mental health services and infrastructure available?
That's a very good question. So, I mean, the way I can answer that is to reflect on my own experience. So I am Jordanian by origin. I'm a Canadian Jordanian. And you're right, in our culture, in the Arab culture, mental health is still very much a stigma and a taboo. And nobody ever talks about it, yet alone seeks services to help with that. So, and we did see that in Canada. So I remember, so when Syrian refugees came into Canada, they were welcomed into sort of what we called them at the time, welcoming shelters. And they were practically hotels that we took over, and we're providing services. And that, if you spoke to any of the Red Cross, because they were in charge of the delivery of healthcare at the time, at those centers, with the local network of primary healthcare centers in Canada. And one of the big problems that emerged was that, people weren't speaking about their mental health. We saw post-traumatic stress disorders, we saw anxiety, we saw depression, and trying to address those needs when people don't voice them, and just from clinical presentations and just seeing the way they interact with others was a massive challenge, and continues to be a challenge. I think that's something that we still haven't figured out quite adequately how to respond to it. So one way that we are sort of creatively thinking about it is awareness campaigns, trying to educate the communities using their own people. So when we identify Syrian refugees in this specific community, that's sort of our pioneers of this idea, who want to engage and help out, we utilize them effectively. And that's a creative way to solve a complex problem, is that let the people speak to their own people, so that it helps the burden of shift. And our immigration centers in Canada, which are in charge of helping refugees and any person who's newly immigrated to Canada to settle into our communities, are tasked with that difficult sort of chore to figure out how to actually bridge that gap.
Exactly. In our third week of the course, we had an interesting discussion question where we asked our course community to consider what will be the first action item on receiving a refugee into a host country. And some of the submitted thoughts were ensuring communication, ensuring interpretation, that there's understanding from a language perspective. Some indicated that, well, you have to assure safety because people are leaving their country to seek safety. Another aspect has to do with the healthcare as well. So from your context, in your work and your experiences, what do you think from the refugee perspective will be their first immediate need when they enter into a host country?
Instinctively, I want to say security and safety, because I mean, if you talk to Syrian refugees, and I'm specifically, because I don't know, I haven't really worked with other populations of refugees, but specifically Syrian refugees, we have to remember that what they left is quite a horrific situation. So I think if you speak to them, you realize that there is whether it's a father or a mother or anybody from that, they left a terrible situation. They're looking for a place that they feel safe and secure. But I would say now, have been somebody who's been an expert in this topic for the past 5, 6, 7 years. Additionally to security and safety comes this need for stability. And the stability comes in the form is, do I have access to healthcare services? So host communities, I think when they're thinking about accepting refugees, they should think very creatively about how do we ensure that they know that they're safe and secure here? Because the reality is, most often they're not. So Canada, I'll give you the example just to be very much more concrete in this answer. Canada, when you are accepted as Syrian refugees, you are like a permanent resident. So we're not accepting you on a short-term basis. There's no expectation that as a Syrian refugee, you're going to go back to Syria. The expectation is that you are welcome in our country and you can stay as long as you want, and you can apply for Canadian citizenship in 3 years like any other person that immigrates to Canada. Now, this is not the same as Lebanon or Jordan, countries that have taken Syrian refugees. Their expectation as a government and as a country is you will leave. We're welcoming you for a short temporary time and you have to leave. And that doesn't address their security and instability that they have going on. It actually just makes it worse and worse on them. So this is why I think it depends on the country. And I'm noticing there's one more question. Does Lebanon have any third country agreements comparable to agreements in Canada and the US to help alleviate the burden? So yes and no. Canada has an agreement with Jordan at the time when we accepted Syrian refugees. They utilized the networks that they're a very strong relationship with the government of Jordan to figure out how to recruit, and I say recruit, I use that word incorrectly. What I meant by that is to target the Syrian refugees that are actually already are housed in their Zaatari camp, which is the largest refugee camp in Jordan. So they've utilized that relationship they have between the two governments. But no, I mean, also, I'm not sure Canada really needs that, because the reality is we're a highly rich resource country. So, and the burden hasn't been that big in Canada. I have to remind you once again that Canada only has taken 54,000 Syrian refugees. That's, in my opinion, that's not a big number that requires us to seek assistance from other countries. I think what Canada is asking is that we of other host communities around the world is to step up and equally take the same number. So they're trying to have a leadership model towards it to demonstrate that this is the way forward, that other communities should also think of the same thing, same approach. I hope that answers your question.
So one of the questions that emerge out of our weekly seminar presentations will be persons interested in asking, how can they get involved? How can they, as a current or as a future healthcare professional, participate now that they're raising awareness and understanding, and also seeking to really contribute to this growing humanity problem as well? How can persons get involved?
That's a very good question. So one of the things that we noticed with the Canadian response to the Syrian refugee crisis is that healthcare providers were not really involved in informing the policy options towards addressing their health needs. There is a need for healthcare providers who are interested in refugee health. And I think that you're very naive not to be interested in refugee health, because the reality is you're most likely going to have a patient who is a refugee. So I think it's important for us as healthcare providers across the board to step up to the policy arena. And I think there are many ways to do it. So for example, in Canada, there's often citizens panels and deliberative dialogues where healthcare providers are invited to come and voice their opinion. And one of those opinions can be as simple as, listen, I don't know what to expect. Like, how do I deal with this population? What are the major health concerns? Do I have adequate resources to respond to them? What are you doing as a ministry, for example, or a local health integration network to help me assist in that? So I think as a healthcare provider, we need to educate ourselves as much as possible about some of the common diseases and problems that come with the refugees into our communities. But B, we need to ask of our policymakers and our government entities to actually support us in delivering those needs. Sorry.
So one of the comments and points that I note as well in your presentation has to do with any discussion on health should include climate change. Now that has relevance to refugee health as well, as we can appreciate issues as water supply and water security can create civil unrest and conflict. Famine and extreme events can create adverse conditions for people to make a decision to flee and leave the place of origin as well. So when we think about the impacts and implications of climate change, there's no one region in the world anymore that's more affected. Climate change affects the planet. So the traditional sources of refugees, we're seeing now that there are new areas of refugees. Even in the South American context, we have the Venezuelan crisis, and that's even creating a refugee issue within South America, as well as even in the Southern Caribbean as well. So from that perspective, no particular country, no particular region can claim that they are devoid or free of a refugee situation. So this is in fact a global issue. And your perspective from the Syrian crisis, as well as your engagement from a Canadian perspective as well, is very instructive, because we appreciate different regions in the world having different reasons as to why people relocate or displace. But at the end of the day, people are displaced and relocated is a profound experience.
And also, I will add to that by saying that a lot of the research now has been focusing a lot about climate change and forced migration, because people are seeing a very tight connection between the two. And maybe that's actually a hope for future governments to sort of pay attention to climate change. So, I mean, this is personal opinion. I think that there's also a fatigue with climate change. I feel like we're using the same tactics to talk about climate change, and I'm not sure it's actually resonating well with government and leaders. So I often wonder, but with my work with migration, whether that that is the twist we need for an old story to make it exciting again.
Yeah.
So I don't know. I don't have an answer for that, but you're absolutely right. I think we're seeing more and more the two are very much intertwined.
Yeah. And what is interesting as well in our course, we asked a question to our community: how would you feel? Put yourself in the shoes of someone who is forcibly relocated. And what are some of the comments from our courses? That many of these persons have either personal or family history of being migrants or being refugees themselves. So a lot of persons can relate personally to the experiences of refugees themselves. And that should hopefully account for a greater level of understanding and empathy towards the plight of refugees as well.
And we saw that in Canada. I think Canada is made out of a land of immigrants. And so I think that's actually one of the reasons why it wasn't a very hard sell to accept Syrian refugees. I think what confuses me and sort of always in the back of my head is why the US hasn't been able to do the same thing. And there's many reasons towards that is not my focus. But yeah, I think it speaks to people realizing that we have more in common than we are have different.
I have one more question for you, and this is just based from my understanding of demographic transitions that are occurring around the world. When we think about Canada, for example, it's an aging population. It's a population as well where even the reproductive rate or the growth rate is slowing down. We think about countries like Germany, similarly, aging population, and these countries will have difficulties replacing the population in a 25-year period. So when we see countries with this type of demographic context, they seem to be a bit more open to receiving persons because there is a critical need for especially younger generation to enter into the country, to work, to earn, to pay taxes as well, and even to fund some of the social services like pensions for the elderly. So from that context, we have two types of situations. We have countries where it's overpopulated, and we have countries where there's a challenge with regards to maintaining and sustaining their population, which has implications to their social, their economic development as well. Can there be a point in time or a geopolitical mechanism where countries or regions can accommodate each other? Maybe through the context of refugees, where supply and demand, need meets outcome, and that type of arrangement to add another layer of how refugees can best be managed.
I agree. I mean, I think that's a very good point. I like the point you brought up about the aging demographic, because that's one of the things that I advocate continuously. Is like one of the reasons that we should be more willing to accept refugees in our community, especially in Canada, is our population is aging. And so reality is that we're accepting healthy Syrians. Like, we're not accepting the very old or the very young. We're accepting middle, very healthy individuals, women and children, with the idea that they're going to be a resource for the country. So I think that's one of the things that go towards changing the mentality and the thinking around accepting refugees, is thinking about them as a resource for the incoming country, especially in communities like ours in Canada with an aging population. And you're right, they pay taxes. We found beautiful examples of Canada where Syrian refugees were able to open businesses and were very innovative. They were very smart in their thinking of changing their circumstances and opening a chocolate shops. They opened bakeries, they education centers. Some of them went to education, and they were an amazing resource in the community itself. So just recently, we saw an example where a Syrian family in Winnipeg stepped up and tried to help the local community itself in terms of safety and security for the population. So I think that is what can be taken away from the understanding of other communities that were able to take them. But again, I want to emphasize the point that only happens when we have better integration of refugees into our host communities. So when we look at Jordan, when they are isolated in a camp, I'm not sure we're seeing as much of that, right? But in Lebanon and here, where they are part of the urban settings, they are able to play a much bigger role.
Definitely. And I think that's where the conversation should progress, where refugees can be considered a positive, beneficial, contributing aspect.
Absolutely.
Towards a host community and host country as well. And if there are no other questions, well, we certainly want to thank you for joining our course and for contributing. We admire and respect the work that you are doing. It is very significant to what we believe is probably one of the more vulnerable groups in our global community. And this is as much a health issue as it is a humanity issue as well for us. And I believe history will sort of define the global response as it relates to how we manage this refugee. In fact, our future will also be inevitably be determined by how we work with our refugee communities. As you indicated, it's only going to become more pronounced, especially over the next 10-year period as well. So certainly with courses like our refugee and migrant health course as part of our open access online course series and the work that yourselves and colleagues are doing, we hope to build awareness and to engage and influence and encourage our course community to be more involved in this particular issue. Thank you very much.
You're welcome. Thank you, everybody. I really enjoyed my time.
Thank you. And that's it for our final week 4 of our course on refugee and migrant health. We have a couple of more activities pending for the course. For those of you who have not submitted your final discussion posting, feel free to do so. We also have your peer review seminar presentation, where you can prepare your recording and share for your colleagues to review and evaluate each other. And finally, for those of you who are interested in gaining credits as part of the course, you can complete our comprehensive examination at the end of this course, and we will provide more information for you on that comprehensive examination as well. So that's it for now for week 4. Thank you one and all for joining us, and until another time, it is goodbye for now.